Okay, so without further ado, it is my pleasure to introduce our first speaker today, Dr. Bill Kohl. So Bill Kohl III is a professor in epidemiology, human genetics, and environmental sciences at the University of Texas, Austin. He's one of the most influential leaders in physical activity and public health in the world, as evidenced by his manuscript in the premier international medical journal, Lancet. Dr. Kohl served as a lead epidemiologist and team leader in the physical activity and health branch of the Division of Nutrition and Physical Activity at the Centers for Disease Control and Prevention in Atlanta. In 2006, he was tapped to help create the first U.S. physical activity guidelines, which were published in 2008. I hope you've all had a chance to see those. A landmark moment in physical activity and public health. These are the equivalent recommendations for dietary intake that the government has done for over 100 years. Also at the CDC, he was responsible for the physical activity assessments for the behavioral risk factor surveillance systems. He is the founder of the International Society for Physical Activity and Health. He's also a faculty member for the CDC Physical Activity and Public Health training courses, not only in the U.S., but also in Brazil, Colombia, Costa Rica, Mexico, Malaysia, Chile, Thailand, Aruba, and Puerto Rico. I'm going to ask him if he needs any help with that after the summit. Since 1984, he has worked in the area of physical activity and health, including conducting research, developing and evaluating intervention programs for adults and children, and developing and advising on policy issues. He's also the author of nearly 200 academic publications and book chapters, and we are so pleased to have him be the keynote speaker for our day 2.
Okie-doke. Thank you, Shelly. Appreciate it. Check. Oh, hi. Good morning. Good morning. Shelly, thank you very much for that kind introduction. I was commenting to Jim across the way that these things seem to get longer the older you get, which is probably true, but Jim in his own wonderful way said that just means you're being more productive. So he's a psychologist. He kind of plays tricks with me. Robin, congratulations. Thank you for inviting me as part of this conference here. I've learned a lot the last day, and I look forward to today. Thanks to Children's Mercy, the weighing in program, as well as all of our supporters who have magically disappeared from the screen. HRSA, the Office of Secretary of Health, and so forth. What I want to try to do today is take a step back. I'm not here to convince anyone. Can I wander? Can you hear me? Okay. I'm not here to convince anyone that physical activity is good. I think we know that. I'm not here to convince anyone about the health benefits, some 38 different chronic conditions, some acute conditions that physical activity can improve or is associated with an improvement. I'm here to take more of a global view and argue about the specific role that physical activity plays in public health. Not population health, not even individual health, but public health. And I make those distinctions not lightly, having worked in public health for a long period of time. I want to try to do that. I want to, in the midpoint, pivot a little bit and talk about the theme that we've been faced with the last yesterday and today, which is a systems approach to change, particularly as it relates to childhood obesity. I'm going to use physical activity as my example. If you are not convinced yet, I do hope after my talk today, the idea of systems approach or change will be helpful. And then if I have some time, I have what, 3 hours? Yeah, okay. If I have some time to introduce a little bit about the U.S. National Physical Activity Plan, which is something I think everyone in this room should be familiar with. All right. I don't know where to point this. If you tweet them, got them there. I like Twitter, and if you're available on it, go ahead and do it. Greetings from Austin, beautiful city. please come visit whenever you're around. That's one of our many lakes that comes through the middle of the city. Great place to live. In 2012, we published, Jim was part of this, several other leaders in the field, published kind of a landmark issue that Shelly was referring to in the Lancet, a high-profile medical journal based in London, all of the papers of which were focused on physical activity. And you can get it online. It's open, free. We can make it available on the website. But there was a startling quote on the front of that Lancet. And it says, if you can't read it, in view of the prevalence, global reach, and health effects of physical inactivity, the issue should be appropriately described as pandemic. Oh, pandemic. Sounds serious. With far-reaching health, economic, environmental, and social consequences. This was a culmination of 3 years of work led by one of our colleagues in southern Brazil, in Pelotas, Brazil, Pedro Halal, to bring this issue to the public's view that this isn't just a clinical problem where we have to wrestle with how to get my mother to be more active or me to be more active, but thinking about it in terms, in the same way we've thought about tobacco control and other public health issues in the last 50 years. Oh, there's the URL right there, lancet.com/series/physical-activity. I don't know where to point this. I'm just pointing it wherever it'll. There we go. This is great. This has nothing to do with my talk. I just kind of like it. It's the way we do things in Austin, you know? Active transportation. So, a little bit of audience participation. There are three things that I always teach my students that make up a public health problem. It's easy to say what a public health problem is. Oh, it affects lots of people, therefore it's a public health problem, but not really. I gave one away, all right? It affects lots of people. What are the other two? Anybody want to shout them out? Criterion, I know it's early. Caffeine's kicking in. Anybody want to shout it out? I know you know it. Come on, guys. I can't even, there we go. It's important. It's got to have a significant health effect, right? It can't just have a minuscule little health effect. It's got to have some kind of very, very measurable and important association with health outcomes. Second, got to affect a lot of people, and we've got to take a look at trends, right? This is fundamental epidemiology. Prevalence and trends. Got to count things. That's the reason why I became an epidemiologist. I can count things. That's about all I do these days. A little more complicated, a little less complicated in some instances. But we have to know how many people it affects, right? And what the trends are. Is it going up? Is it going down? Is it stable? And then third, we got to know what to do about it. We got to have solutions that are evidence-based to be able to do something about this public health problem, right? Acting on behalf of the population that we're serving, we've got to know ways to approach this. We can't just define the problem, say it's important, and throw our hands up and say, next. I submit that when we talk about a public health problem, all three of these factors need to be checked off on the box. And I think I'm going to make the case, and a lot of what we did in that Lancet series, make the case that physical inactivity is a global public health problem. Talk about importance, burden of disease. I'm not going to go through all the calculations, but one of the most important papers in that series pointed out that 6 to 10% in 2007 worldwide of non-communicable diseases could be attributable to physical inactivity. Whoa. Talk about, there's some, does this work? Yeah, it does. Some calculations and so forth, but online, when you calculate these with the major causes of death, around the world from non-communicable diseases. 6% of heart disease, 7% of diabetes, 10% of cancers, and 9% of overall mortality. If you erase all physical inactivity around the world, you magically wave a wand and have everyone meeting physical activity guidelines, it would theoretically erase 6 to 10% of all non-communicable diseases. Varies by country, it varies by population, disease burden, and so forth. But that's a remarkable statement in my mind. Right off the top, 6 out of 100 or up to 10 out of 100. So it seems pretty important. And this was the elevator speech. When you compare it to other causes of death that have been calculated other ways, estimate that 5.3 million deaths were due to physical inactivity, compared in 2007, compared with, 5 million deaths due to smoking. Now, the things are complicated. I'm not saying that physical inactivity is any less important, or smoking is any less important than physical inactivity. But the sheer fact that the way the smoking researchers have calculated their population attributable risk is roughly equivalent, I'm not going to quibble about 300,000 deaths, is roughly equivalent to physical inactivity, should get everyone's attention. And this is the source you might have heard over the last couple of years in the popular media. Some people are talking about sitting being the new smoking. I don't agree with that. But this is the source of those comments. On a population level, there is a remarkable argument to be made that physical inactivity is as important a risk factor as cigarette smoking, and probably even a little bit more than smoking. And this set off lots of arguments in the literature about how to calculate things and so forth. My money's on these numbers because the author, Min Lee, is one of the best epidemiologists I know. The point being, it's not insignificant. We've got to pay attention to these numbers as an important public health problem, number one, in our public health problem definition. Pandemic. What do we think about when I say pandemic? Somebody awake now? Worldwide. Worldwide what? Web? Worldwide issue. Okay. Good. Take a star out of petty cash. You think of these really weird things, SARS, communicable diseases that are spread through mosquitoes and bats and fleas and things like that are very hard to control. The sexy part, if you will, of epidemiology, where they make movies out of and people jump out of helicopters and so forth. This is kind of what we think about when we talk about a pandemic. I submit that physical activity or physical inactivity meets all of these criteria and should be considered as much of a pandemic as some of these other things, tuberculosis and so forth. So I went and got the definition out of the Dictionary of Epidemiology. A pandemic is an epidemic occurring worldwide or over a very wide area, crossing international borders, and usually affecting a large number of people. And an epidemic is the occurrence in a community or region of cases of an illness, my bold there, a specific health-related behavior or other health-related events clearly in excess of normal expectancy. Right? So do we have a pandemic of physical inactivity? Jim showed a map yesterday that kind of listed it out. In words, though, the analyses, and it hasn't changed much in the last 5 years, about a third of adults, okay, and about 80% of adolescents are not reaching public health guidelines for physical activity. Think about that. A third of adults, 33% of adults, but 4 out of 5 adolescents, ages 13 to 15, are not meeting what the guidelines are saying are the minimum health-related physical activity exposure. What if 80% of adolescents were smoking? What if 80% of adolescents were using fentanyl? Any of a number of other exposures that we've considered public health problems currently, and we're trying to deal with appropriately. We'd be up in arms. Congress would be all over it, right? People are dying. It's an important public health problem, and at least in kids, 80% of them aren't meeting the recommended physical activity guidelines. To me, that's an urgent public health problem, right? We know a little bit about boys and girls and so forth, but to me, it crosses the world. The maps are very clear that it doesn't stop at borders. There's no national policies that stop things here or there. It takes a little reframing to be thinking about an NCD or a behavior for a non-communicable disease as a pandemic. But I think that we must think about that if we're going to do something about it, away from just what's right in front of us. Locally, I grabbed these data from the BRFSS last night. I don't know why that's showing right in the middle of us here, but in this particular case, percent of students in grades 9 to 12 who hit an hour or more of moderate intensity activity every day. 27% in the US in 2015. That closely mirrors the national data, right? Where we said only 20% met them, 80% did not. These are the US data. And we've got maps. 2015, the percentage of students who have obesity, these are kids 9 to 12. You can see the dark blue is the highest prevalence, the light green is the lowest prevalence. Data unavailable. Kansas, Iowa were unavailable for 2013. These are, the YRBS data. You can see, but here in the South, we continue to have these problems that we always do. The dark greens are worse, and the lighter greens we see generally out west. So we can develop these patterns. We overlay physical activity. Blue is higher. Sorry, I'm fumbling with my pointer here. The lighter green is a lower percentage, and the darker ones are the higher prevalences. You can see we're doing a little bit better in this particular area in the Midwest, certainly in the West and over here. We can map these things pretty well by state, by region, by country, based on our available data. It's not just an international problem, it's a problem right here at home as well. And a lot of people here I know are interested in work in the rural areas, particularly here in the Midwest. Rural is not rural when we talk about physical inactivity. We talk about transport-related activity, discretionary or leisure time activity, household activity, and occupational activity. This is a paper that was published a few years ago now, but it shows really big differences. This is from N. Haynes, between accelerometry-devised measures, measures of physical activity between urban population, rural population, and then separating rural population into the non-micropolitan, that is the less dense, and the micropolitan or more dense but not quite urban areas. You can see differences across the board. Almost half in micropolitan of adults in this representative sample are meeting guidelines based on accelerometry. So I think it's doing a disservice to make the case that it's just rural and urban differences. There are real differences that have their roots in the type of measure or the domain, total, leisure, household, or transportation. You can see things are very different across these prevalence estimates are very different across these designations of rural versus urban. We've got to be thinking more about context, I think, whether it's nationally, internationally, or here in this particular case, specific parts of our nation. The third thing that I think is really important is we need to know what to do about this problem. Jim Salas has led the way many years in trying to figure out what to change. We talk about behavior change. He introduced the socioecologic model. Our thinking has proceeded. We know a little bit. We know more about what's correlated rather than what precedes change in physical activity, but we know enough to be able to start. Lots of factors have been studied. Gender appears important for children and adolescents. Physical environments, active travel to school we've talked about, as well as recreation, seem to be associated with higher prevalences of physical activity for children and adolescents. For adults, there's differences by age, older being less active, gender, men being more active, health status, people who have some kind of underlying condition being less active, education, people with higher educational status being more active. There are some social, psychological things for adults that are showing up, and as Jim talked about, environmental correlates that are really starting to give us some ideas. Now, that's not to say that these are determinants. The difference between a correlate and a determinant is one precedes the other, and most of the studies we have not allowed us to study a change in these factors versus a change in physical activity. It's been a correlational study. It's been one of the weaknesses that we need to address. That doesn't mean we can't start, right? The old story about John Snow and the pump handle in London and Soho in the 1840s, way before the germ theory. He mapped out where all the cholera cases were and decided that it was close enough to the pump handle, to the well, to remove the pump handle, and the cholera cases went away. He didn't have cause and effect. He had some correlational data and was able to parlay that into a legend now, but he saved a lot of lives accordingly. We know what works. The Guide to Community Preventive Services Task Force has very clear recommendations about the evidence that are effective, things that are effective versus promising, and some emerging techniques in campaigns and informational areas, in behavioral and social, policy and environmental. There's a whole website at the CDC from the the Guide to Community Preventive Services Task Force that details these things and summarizes what's effective. It's absolutely necessary if we're going to address a public health problem, right? We've got an important problem. We've got a problem that's prevalent, right, in children and adults, and now we've got at least enough information to be able to make something happen and do what we know can affect it. I just gave this slide. You know, prevalence and trends, magnitude and risk, it's important. I didn't talk about the global consequences, economic consequences that are starting to emerge, quality of life issues, and we know what to do about these things. To me, it creates an action priority for public health. Not just clinical, not just in our little areas, but something that requires a global response, a systems approach to making this go away. Just like, again, I keep going back to what the tobacco control people have been able to achieve. In the US, it's been a lot better than China and other places that are increasing their prevalence, but I do think that we've got a model to follow, and that's in the tobacco control area. So one of the papers defined what the next steps were in the Lancet series, what we should be doing, define the systems approach to creating a call for action to make this happen. I really don't know where I'm aiming this. There, we've seen that before, haven't we? It's amazing how frequently, we hadn't coordinated this, but it's amazing how frequently this socioecologic framework for determinants of physical activity shows up. It's one of the many contributions that Jim Salas has made to the field over the years, helping us think through this thing and understanding the multiple levels from interpersonal all the way to policy and environment. And yesterday, who was the speaker from the management? Dr. Renz. I was rapt at attention with his talk. I can't remember his name, but I was rapt at attention with his talk because he was saying all of the things that from a different perspective that I've been thinking and we've been thinking about in this particular paper. Maybe there's a exterior circle on this that encompasses everything, one outside environmental policy that brings the systems together. And I think we have to be thinking about, this has been used to make individual behavior change. It's entirely appropriate. There's various domains of physical activity, the leisure, the occupational, the transport and household, so forth. But what's controlling the system that makes these changes? I think the fundamental assumption that health behavior for you and me and whoever we're dealing with on an individual level equals public health is a flawed assumption. The sum of the individual parts does not equal the whole when we talk about public health. Research and promotion for what we've been doing about has tried to integrate exercise science, public health science, behavioral science, environmental sciences. But public health requires a complete integration, not each of these individual areas in my mind, but a complete integration. And I submit that this complete integration for these interrelations, we haven't quite gotten there yet. We will, I think, if we do this public health approach. Jim's not going to like this particular thing. This is a dead horse. You know, I was thinking, no one's made a joke about everything being up to date in Kansas City yet. Is that old? Okay, never mind. It has nothing to do with this. I think from a public health standpoint, the thing we have to be thinking about is maybe the socioecologic model needs some tweaking. Maybe we've ridden it as far as we can to develop without an understanding of systems. Everyone's very supportive of it. I think it's the best we have right now for individual behavior change. But the prevalence of people meeting guidelines in the United States is, particularly leisure time physical activity, has been steady for 35 years. We haven't moved that needle at all. Right? We've got this 8 out of 10 kids around the world, adolescents, who aren't meeting guidelines. We continue to focus on only relying on the socioecologic model without an understanding of the systems in which people live and which populations live. We may be selling ourselves short. So the question is, have we ridden this horse as far as we can in terms of public health? Okay? This is one of my favorite quotes. The whole concept of public health is founded on the insight that health and illness have causes or conditions that go beyond the biology and go beyond the behavior of the individual. Right? Most of you are public health professionals and understand that very well. Lots of people stop at the biology and the behavior and don't think more broadly about public health. And I think that that's what one of the things we've got to change for physical activity. I think we have to think differently. This is on the other side of Easter Island. You don't see this all the time. They don't show that to the tourists too often. You've got to step out a little bit and be thinking a little differently from what we have traditionally done. Okay? I think we have to focus on this idea of a complex system. This looks pretty simple. This guy is sitting here. He's got a problem. He's trapped. He doesn't really know what to do, but the problem seems to be solvable by knocking one of the walls down. Except when you don't consider the unintended consequences of what you're doing. Except when you don't consider things like delay functions, or as Dr. Renz yesterday was talking about, things working against you. Right? We like to think that we're doing great work and everyone should be for us, and there shouldn't be any resistance. That's just not the case. One of my favorite examples of that, I was working on an IOM committee report some years ago, and I went in fairly naive, and asked the question of a very, very famous PE coordinator from Miami-Dade County in Florida. I said, who could be against kids having more PE? Where's the resistance? She said, oh, it's all over the place. Music, art, dance. Because they were being pitted against each other for available time. Well, we'll cut one of them. And so they got to be infighting between all of these, quote, non-essential or non-core subjects, right? And I had my eyes wide open. I said, this is kind of silly. Why is the art department fighting the PE department? We should be doing all of that. We've got to be considering who's against us, what's against us, and what those unintended consequences might be, so that we can better understand the whole system and not just this situation, right? Got to be kind of taking a step back. It's an extremely complex behavior. We've got to understand that. I'm not regularly active all the time. None of us are. None of us eat well all the time. It's just kind of a similar thing. It's incredibly complex. It's not linear. X does not equal Y all the time, or 2x equals Y. There are interactions, adoption delays. A lot of our studies, for example, work in 5-year increments because that's what the government funds. What if it's 10 years before an entire system can be changed? What if it's 20? Right? That doesn't fit into our funding model or some of our careers in terms of how long we're going to be around, right? Taking a long view, those adoption delays may be quite kind of in the way. The system may adapt, right? It may change, much like a antibiotic-resistant bug does. And all of a sudden now you're not dealing with the same target you are anymore. Competing actions we talked about and unintended consequences. All these things have to be considered in the context, on the outside rim, if you will, of the socioecologic model. Understanding those multi-levels, but then the system in which we're dealing with, we've got to be thinking about that. I really am pushing this, guys. And a systems approach, and there are whole books written on systems approach. Dr. Renz is an expert. Inputs and levels of influence are considered to be interdependent, not independent. That is, the multiple levels and inputs depend on each other. We've got to identify things like what enables something to happen, what might accelerate a reaction, what's an enzyme that might change the natural course of an intervention, changing the behavior, synergies and interconnectedness and so forth. This, I think, from a public health standpoint, has the highest potential to affect population-level physical activity. I took this photo. This is at the San Francisco Convention Center. This is the requisite look at the dumb people on the escalator photo. But I took this because it was extremely striking. This was the 2011 annual conference of the American College of Cardiology. These are smart people, right? They know. You can't, education isn't going to change this behavior. I'm sure they're all going to go running on the Market Street or something later on in the day, but you can see 95% of them are taking this escalator up, and putting the stairs right next to things didn't help, right? The environmental change, you could shut the escalator off maybe, but the stair isn't hidden anywhere. Right? These are smart people. If we can't change cardiologists' behaviors, something's not right. We've got to be thinking more in terms of a system rather than individual behavior change. So, the typical model where we kind of think, and I was trained on, you've got a problem, you get physical inactivity. Apply a behavior change theory, stages of motivational readiness, whole bunch of theories that health behavior experts have helped us to understand. You apply that theory, you make some changes, you intervene, and you come up with behavior change. You publish your results, you get nice funding opportunities, you get tenure, everything works out great. And you become one of the experts in the area. It's the way we've kind of operated, right? Jim has helped us understand another model where environmental approaches take a problem, you make a policy or environmental change, right? You get an environmental intervention, and then you get a behavior change, right? This idea of policy or environment, the outer rings in the socioecologic model. You get published, you get a nice new grant, you get tenured and promoted, and everybody's happy. Nothing has really changed, though, for people who weren't exposed to those things. There's no systems change that we're understanding. I think that one way to be thinking about this, I'm going to morph this figure a little bit. We've got a problem, physical inactivity. We've got an outcome we're looking for, behavior change. Here we've got the same things, behavior change theory, environment and policy changes. Now notice I didn't say intervention, I put strategies and implementation. I think we have to be thinking away from, quote, interventions to changes, lasting changes, implementation changes, and then behavior change. But wait a minute, what's the system you say? Did anyone say that? What's the system you say? Well, there's various domains here. Each of us deal with every day. You have kids, you have parents, your family, and so forth. There's the education sectors, health sectors, city planning, built environment, transportation sectors. We cross most of these sectors. Each of us cross most of these sectors every day. They're all interrelated. So an intervention in the school setting, education, by itself isn't going to change anything over here where we're all working, for example, in the workplace. Or the transportation sector. We learned about bicycle commuting in Kansas City yesterday. We have to be thinking about this. I strongly believe that we've got to consider this entire system rather than a simple, and it's not simple, I'm not trying to minimize it, but a single area. We're going to hear about the healthcare system in the session after today. That's great, it's terrific, but what about the rest of these systems? How are they coordinated, these sectors? And then overlaying these ideas that are relevant to systems change, adaptation, unintended consequences, delay functions, things that might inhibit, things that might accelerate people or things competing against you. Okay? So this entire thing, it gets a lot more complicated rather than a few lines from behavior change theory to behavior change, or environmental change to behavior change. We're starting to kind of understand this, and it's maybe not as complex as the UK system of systems change. That big spaghetti diagram that we saw yesterday. But it does indicate a level of complexity that we haven't yet dealt with, I think. And I think that's where we need to be going. What time do I have? 9:45? Oh, I got. Can I have another PowerPoint, please? So, I hope I've been able to convince you, since I'm up here and I have the microphone, that number one, physical inactivity is a global public health problem. It is a pandemic. We have strategies that work. We need to deal with this on an urgent way that we haven't been dealing with it before. And I also hope that from a systems approach, you've gotten a little bit more of what Dr. Renz was talking about and other speakers have been talking about today. What is the call to action, though? What do we do? What is the way, the approach Okay, he's up here talking about a systems approach. What does that actually mean for implementation? Well, we wrote in this particular thing, and we've written other pieces about this, it takes all the way from the UN and the World Health Organization to individuals and organizations like this to make this a priority. Not just give it lip service, but make this a health priority, such as tobacco control. And I think if you believe that it's as important from a population attributable risk perspective as smoking is, then it requires a response that is at least as great as we've been able to muster in the last few years against smoking. Some examples. We call for the UN, the World Health Organization, to provide leadership in a systems approach to national physical activity policies. Okay? World Bank, other foundation supporters, countries, action plans, develop strategies for planning, give a relevant government agency authority to do this kind of work, look at evidence-based policies, and so forth. Some things that are already happening in the US that are actually really good. Various ministries, health, it's not just, Jim was talking about yesterday, it's not just the health department that the problem is. And in fact, the health department, the Ministry of Transportation, the Ministry of Planning, Education, and Sport oftentimes don't talk to each other, right? We don't even have a, quote, Ministry of Sport in the US. Most other countries do. And this is where it would reside, this kind of thing would reside in other countries. But it's largely been thought of as a health DHHS problem, but absolutely the Department of Education and Housing and Urban Development and so forth have to take this on, I think. The systems in which we live. And down at kind of individual levels, employers, academia, academics, even individuals, there are some suggestions there to do this. The point is, it's everyone owns this. If you believe that it's a public health problem, just like tobacco control. And how do we marshal or call to action everyone, every type of organization to make progress? I took this photo some years ago, and I actually got a release from these two because they thought I was actually creeping on them. And I said I'd like to use this in some lectures, and I think they'd had a couple of beers there at the barbecue place. So. Just last month, the World Health Organization responded to that call and released a global action plan for a healthier world, more physical activity as part of the global action plan for control of non-communicable diseases. World Health Organization website, you can find it, but there is a large guidance document going from 2018 all the way to 2030 now that was in direct response to the work we did from the Lancet. It calls for goals to reduce physical inactivity worldwide by 10% by 2025, and then accelerating that to 15% by 2030. I'm not going to go through all these. You can get these, and we can make them available. 3 kind of key goals: create active societies, active environments. 4 goals, I'm sorry: active people and active systems. It's starting to show up more and more these days, this idea of a systems-based approach. World Health Organization is taking the lead on this right now. And it was really fabulous to see these things come out as part of their non-communicable disease plan that the WHO Director General released last month. I want to touch a little bit on the U.S. National Physical Activity Plan. Has anyone heard of the National Physical Activity Plan? Few people. Yes? I think that this is this preceded the Lancet, the efforts preceded the Lancet series, but this is another example of one of the actions that we called for at the national level. The U.S. National Physical Activity Plan was originally released in 2012 or so, 11, and then updated and released April 2016. And it deals with the idea of the sectoral or systems approach to promoting physical activity. Those of you who work in this area, I think it's a great resource to be able to rely on. It's a comprehensive plan that is meant to bring goals and strategies to increasing physical activity across the population, across the U.S. population. And it's comprised of overarching priority strategies and tactics to be able to do this. Not just say, let's go do this. There are actually strategies and tactics that are recommended to do this. There's a timeline, 2007, 8, I'm sorry, it was 2010, not 11, released the first National Physical Activity Plan. So it's still fairly new. There's a nonprofit that supports it, updating and revising it 2016, or 15 and 16. Sorry, this is much more dramatic when this thing happens every time. And there's the updated plan. So over the course of the last 7 years or so, it's gone through several revisions. I think it's pretty darn good right now. And it details lots of partners, as you can see. It's not just, as we all know in public health, are critical for success. It's not just one group of people. It's a coalition of people coming together to make this happen. 7 key priorities, much like what we talked about in the Lancet series. A federal office of physical activity and health. Right now there's a branch in CDC where I used to work that's responsible for a tiny proportion, but all that the U.S. government right now is doing on this. There is a federal office of smoking and health. If in fact physical inactivity is as important on a population level, why don't we have the same response associated with that? Lots of data we don't know about, a comprehensive surveillance system, a lot of data, particularly in younger kids. We're talking about childhood obesity. It's very hard to estimate prevalence and trends in kids under high school age in this country because national survey and trend data don't exist, right? National Physical Activity Report Card has gotten its start. We heard about that yesterday. Policy development, campaign, state and local physical activity plans, and advocate for increased funding. One of the projects I've been working on the last year is trying to detail across the country each individual state physical activity plan. CDC has developed a lot of funding for NCDs, and that goes to states. There's diabetes plans, there's heart disease plans, there's several nutrition-related plans. How many states actually have a physical activity plan? Shout it out. Oh, that was too easy. California, that was too easy too. California's always ahead of the game. 2, West Virginia and Texas. Standalone physical activity plans. When I got to Texas, I was responsible for developing this. And the resistance from the health department was fascinating to me. I tried to get them to buy into this and had meetings, endless meetings. Instead, I went through the governor's office at the time. But a lot of people felt that we were competing against their own plans. The diabetes people were saying, oh, you're going to take stuff away from us. The heart disease people, oh, you're going to take stuff. In fact, what this plan, these standalone plans do is it actually helps chronic disease or NCD plans make physical activity more important. It gives them more strength than it does takes away or dilutes their efforts. That's my opinion. It takes a rethinking, though, of moving physical activity to the forefront of what we think about. The physical activity plan talks about societal sectors, all the way from community, recreation, fitness, and parks. I did a little bit of this yesterday. Faith-based settings becomes so important in communities and systems, businesses and industry. We'll hear a little bit from the healthcare sector today. Mass media, all of these things interact. We interact with these sectors every day. Most of us touch most of these sectors, right? Physical activity should be part of each of those sectors in a system. This is an example societal sectors, kind of making the case. You can see the website, some of the rationale, strategies that are recommended by the plan. Provide opportunities, incentives for employees to adopt healthy lifestyles, engage in partnerships, create and disseminate business case, advocate for policies, support the development of surveillance systems. These are all developed in each of these scenarios. So wherever you are in your work, this National Physical Activity Plan provides some backup, provides some ammunition, if you will, to advance the case for physical activity across all these sectors. Take a look at it. If you work in public health practice or in some kind of a sector that is touched by the National Physical Activity Plan, it's well thought out and provides a roadmap for what we need to do, I think. Tactics, those strategies and then tactics, incentives for healthy lifestyle. For example, worksite health screenings, engage in partnerships, explore methods to expand products and marketing and sponsorship. Website has all of this. I'm not going to go over each of these. It'll take forever. But it's a very well organized approach to what we can be able to do in each of these sectors to advance physical activity as a priority. It is a puzzle, though. It's not something that's going to be painted overnight. We've got to find the right interlocking features to create the system, right, to advance physical activity and public health. I really am pushing this. I think I'm going to leave this there. I've been talking nearly an hour, and I don't even like to hear myself talk for 30 minutes. I did notice that the echo's gone. I do appreciate that. I was worried that I was going to have to hear myself talk, and that would even be worse. I hope I've left us today with at least, if you're buying what I'm selling, with at least an understanding of physical activity as a public health issue, not just as an individual health issue, not just as a clinical health issue, but something that affects populations worldwide. It's important, it's prevalent, we know what to do, we just need we need to make it a priority from international to national to local organizations like what you all are doing here to actually try to make a difference in things like childhood obesity, heart disease, and so forth. Thank you all for your time.